Thank you for the great introduction, Maria. So today we're going to talk about lessons learned from diabetes prevention and diabetes self-management education and support. And we're going to talk about just the differences between the two programs and give you a little background on the process for each and how those both work. So at the end of today's webinar, participants will be able to define the National Diabetes Prevention Program and the national standards for DSMES. They'll be able to discuss strategies to enroll, engage, and retain participants in both services, highlighting best practices for clinical referrals, community engagement, and leveraging other health education resources. Be able to identify approaches to address health-related social needs that are often barriers to retention and adoption of healthy self-care behaviors. You'll hear from Gateway Community Health Center about their success in diabetes prevention program. So before we get started, we're going to be covering parallel pathways to serve your community. So first, the Diabetes Prevention Program. Diabetes Prevention Program is an intensive 12-month lifestyle change program focused on healthy eating, being active, self-monitoring, and healthy coping. It's intended for people with prediabetes or people with overweight or obesity at greatest risk of developing type 2 diabetes. Group programs are led by community health workers and other trained lifestyle coaches in clinical, community, and faith-based settings. Reimbursement is available for Medicare and some state Medicaid programs, as well as some private payers. The benefits of the Diabetes Prevention Program, which is an intensive lifestyle change program focused on, as I mentioned, healthy eating, being active, self-monitoring, healthy coping, was twice as effective as medication in reducing risk of developing type 2 diabetes. Participants over 60 years of age reduced their risk by 71%. The Centers for Disease Control and Prevention provides the seal of approval to organizations that achieve program goals in setting national standards that ensure the quality, fidelity, and broad use of proven prevention programs. Maintain a national registry of organizations that deliver effective diabetes prevention programs and provide technical assistance to organizations to achieve and maintain their recognition status, which I think our presenter a little bit later has some great news to share on that front. Diabetes self-management education and support, on the other hand, is a collaborative, individualized, ongoing process that helps people with diabetes develop the knowledge, skills, and behaviors to make decisions to manage their diabetes and stay healthy. This program is intended for people diagnosed with type 1 or type 2 diabetes. It involves one-on-one and group programs led by diabetes care and education specialists, health professionals and paraprofessionals, and community health workers working as a team. Reimbursement is available for Medicare, some state Medicaid programs, and many private payers. The benefits of DSMES with people with diabetes, things to consider, is that DSMES provides the critical education and support for implementing treatment plans that align with those plans that were provided by the referring provider. It also reduces emergency department visits, hospital admissions, and hospital readmissions. DSMES also reduces hypoglycemia. It reduces all causes of mortality. It lowers A1C. It promotes lifestyle behaviors, including healthful meal planning and engagement in regular physical activity. We address weight maintenance or weight loss through DSMES. Enhances self-efficacy and empowerment in people with diabetes. Increases healthy coping. Decreases diabetes-related distress. It improves quality of life and more. And guess what? There are no negative side effects to either of these programs, and Medicare and most insurers do cover the costs. So if DSMES were a pill, would you prescribe it? So this slide compares the benefits of DSMES or medical nutrition therapy with kind of the frontline therapy for diabetes, metformin. You've probably all heard of that. So when you look at the criteria, which is often associated with drugs, you can see that metformin has high efficacy. So does DSMES. Hypoglycemia risk is very low with metformin as a medication, as is with DSMES. Hypoglycemia is low, if not preventable. Weight is generally neutral or weight loss for both. But when you get to side effects, you'll see there are no negative side effects with DSMES. But with metformin, there may be gastrointestinal side effects. For cost, metformin is low, but DSMES and MNT offer cost savings potentially in addition to being low cost. And psychosocial benefits are benefits that you can expect to receive from DSMES, but cannot be received from taking a pill. So a lot of the factors that improve diabetes self-care are associated with DSMES. The Center for Medicare and Medicaid Services regulations state that a DSMT program, DSMT stands for Diabetes Self-Management Training, which is the term that used to be used for DSMES. We've evolved, but Medicare still calls it DSMT. So we're talking about the benefit, we'll say DSMT. But programs must be accredited by a national accrediting organization so that Medicare can determine if the program meets the program requirements. ADCES is one of 2 certified national accrediting organizations for Medicare, and our program is called DEAP, Diabetes Education Accreditation Program. High-level overview here is for DSMES, there are national standards and accreditation for both of these programs, I should say. National standards and accreditation or recognition for both DSMES and for the DPP. Both programs offer options for billing and getting reimbursed by Medicare. They both have specific staffing requirements, specific delivery modes where they can be offered, training that may be required or part of becoming one of these types of programs. They both involve a curriculum and quality assurance. And so we're going to dive into some of these details over the next hour. And so as we move forward, we will be comparing the commonalities between the 2 programs, and then we'll talk about some of the differences. So on the left side, DSMES has national standards. The national standards for diabetes self-management education support are updated by the Association of Diabetes Care and Education Specialists along with ADA every 5 years. We're actually beginning that process right now. Our first meeting is Friday. So changes to those national standards to meet current evidence are in process. After that publication is completed, both organizations determine interpretive guidance for programs that are applying for and maintaining accreditation, and those are reviewed and approved by Medicare before applying to the accreditation process. For the diabetes prevention program, the national accrediting body is the Centers for Disease Control, CDC. The national standards for the DPP are updated by the Centers for Disease Control and Prevention every 3 years. Again, as with DSMES, new standards should be arriving very soon, a little bit sooner for the diabetes prevention program. We're expecting those in May of 2021. And the CDC Customer Service Center can support those standards and help answer any questions. When it comes to recognition or accreditation, as I mentioned, DSMES has 2 national accrediting organizations for Medicare. ADCES is one, and our program is called DEAP. We offer DSMT accreditation, and that's what we call it at ADCES. The ADA also has their education recognition program, and they call DSMT recognition. But these 2 programs follow the same national standards and offer the same certification through Medicare, through our organizations as approved by Medicare, I should say. For the diabetes prevention program, there's a single national recognition organization with 3 levels of recognition. So the Centers for Disease Control and Prevention, as I mentioned, oversees the diabetes prevention program. And the 3 levels include pending, preliminary, and full recognition. So those with preliminary and full recognition have a standing to become Medicare DPP suppliers through a separate process. Now some definitions. DSMES, Diabetes Self-Management Education and Support, and then DSMT, Diabetes Self-Management Training. By the end of this presentation, you're going to feel like you've eaten some alphabet soup, as with all the different acronyms we'll be sharing. But just to know that DSMES is the professional term that we use for the service. However, when you're talking about billing, we often say DSMT, but these are the same thing in practice. For diabetes prevention, some more alphabet soup. We've got the CDC Lifestyle Change Program, the CDC LCP. The National Diabetes Prevention Program is the National DPP, and the Medicare Diabetes Prevention Program is the MDPP. These are all along the lines of the same program. They just have little different nuances in terms of implementation and billing and support. So, as we talk about billing and getting reimbursed and staying sustainable, DSMES does require a referral from a qualified provider. The provider must be the person managing the individual's diabetes. So a nurse practitioner, a PA, a physician, a DO can all refer for DSMES as long as they are the person, the provider who's managing that person's diabetes clinically. DSMES is offered has individual and group benefit with annual limits beginning the first year of Medicare coverage. And there are a little bit differences with the delivery when we're talking about federally qualified health centers and rural health centers, as they only deliver one-on-one as opposed to group sessions for reimbursement. So that is DSMES. For billing in the prevention program, the DPP, individuals can self-refer into the Medicare DPP, meaning they don't need a formal referral order from a provider in order to be reimbursed. It's a group benefit, and it's a once-in-a-lifetime benefit for Medicare beneficiaries. The in-person program has some telehealth flexibilities as well and can be offered in clinical and community sites. DSMES, as I mentioned, requires a referral from a qualified provider. Individual and group benefit with annual limits beginning that first year of Medicare. And as I mentioned, there are differences between federally qualified health centers and rural health centers. The biggest difference right now is that FQHCs and RHCs only provide DSMES for reimbursement on a one-on-one basis. So group sessions in these settings are not reimbursable. This is a sample or referral template that's available on our website. So it provides you with a sample order form, which you could print and use, or you can use it as a template to build into your electronic medical record, or use the information here as the basis of your referral order and add specifics that may apply to your program, your services, and your health center. This is available at diabeteseducator.org/refer-DSMES. And on the right is just a snapshot of it's about I can't remember, I think it's about a 7-page backgrounder that provides a lot more detail on the benefit, the coverage, and some different scenarios to show how the benefit can be used and the number of hours and all the details there. So that website that I mentioned on this link provides a lot more information and tools for you, including a downloadable PDF of the referral order form that you are free to use. This was a collaboration between the Association of Diabetes Care and Education Specialists, the American Diabetes Association, and the Academy of Nutrition and Dietetics, to come and align with the same requirements in the same form to alleviate confusion and hopefully increase access. Diabetes self-management training includes up to 10 hours of initial training once the person is on Medicare. 1 hour can be individual for any program. As I mentioned, if you're an FQHC or a rural health center, all of those hours will be individual. So 10 hours will be individual. But if you're in a hospital or private practice or another type of setting, 9 hours are typically billed as group unless there's barriers to group learning. And those barriers need to be identified by the referring provider, or if there's no group class available within 2 months, the participant can receive individual DSMT training. Every year that a person lives with diabetes and is on Medicare, they have 2 hours of follow-up available every year, starting on the second year. They do need a new referral each year to receive this, and these sessions can be individual or group, whatever makes sense for the setting and the program. But again, FQHCs, it's only going to be reimbursed on an individual basis. Same with rural health centers. Typically, the individual visits are added to the cost report. For DSMT reimbursement, giving you a sense of the billing codes and a average payment. It's a national average. The code for DSMT, we call them the G codes. And there's 2 codes that you receive access to and can be reimbursed for once you become an accredited program. One is G0108, and that's for one-on-one DSMT. And the average rate is about $52.50 for 30 minutes. The G0109 code is for group sessions. So each person would be billed that code in a group setting, and the reimbursement rate is a little bit lower, about $14.58. Medicare, as I mentioned, allows 10 hours once in a lifetime for the beneficiary, but 2 hours every year. And being sure that that diagnosis of diabetes and referral order is signed by the appropriate provider. For diabetes prevention program, individuals can self-refer into the Medicare DPP. It's a group benefit. It's a once-in-a-lifetime benefit. And the in-person program does have some telehealth flexibilities, and it can be offered at clinical and community sites. For the Medicare DPP, even though individuals can self-refer into the program, a quality referral from a healthcare provider can really increase enrollment, engagement, and retention. When that referring provider says, hey, I think this is going to be a great program, I would encourage you to give it a shot, then it is much more likely that the person with prediabetes is going to pursue that referral or consider. So getting a referral from a provider definitely helps, even though it's not required. That bidirectional communication between the program and the referring provider can also increase referrals. So for those diabetes prevention programs, making sure that those referring providers know what's going on with the participants that they referred, that they're getting updates. Individuals can begin services and one FQHC and complete them at another. There's a bridge payment, sort of a navigation versus a referral. Other complexities of the Medicare Diabetes Prevention Program is that there's a separate process to become a Medicare DPP provider outside of the CDC process. So first, the program has to reach preliminary or full recognition with the CDC, and then they can apply to CMS. FQHCs, rural health centers, hospitals, churches, and community-based organizations are treated equally under the Medicare DPP. There's a whole second year of Medicare DPP ongoing maintenance, but only for those who achieve 5% weight loss in a year and maintain it on an ongoing basis. For Medicare DPP reimbursement, the claims are based on individual outcomes, as you heard, 5% weight loss and other outcomes. There are 15 different G codes related to attendance, retention, and weight loss. Reimbursement can range anywhere from $704 to $203 per participant, depending on those outcomes. And researchers show that those over 65 definitely overperform in the CDC lifestyle change program, meaning they definitely do better and see better outcomes for the most part. I'm not going to go through all of these billing codes in specifically, but you can see there are different codes, different payment amounts for each portion. So once they've attended one core session, which is the beginning, there's one reimbursement. And then there's a different code for the 4 total core sessions. And as we move through, I have a few slides here to cover all of the different codes, as you can see how that payment amount would be added up. A little bit different than fee-for-service with DSMES. So there are different program settings for the programs. DSMES can be in a federally qualified health center, in rural health centers, pharmacies, any health centers, hospital-based clinics, medical practices, community centers. I don't think I mentioned hospitals and health systems, but those are also places for DSMES. For the diabetes prevention program, those can be almost anywhere, and they definitely have a bias for the community. So places like the YMCA, University Extension Services, faith and community-based organizations, hospitals and health centers, FQHCs, rural health centers and community health centers, pharmacies, and private businesses. And they can be provided online except for Medicare. DSMES can be provided online or web-based during the public health emergency, but that is a current waiver. For program oversight, DSMES requires a quality coordinator and at least one professional instructor with credentials such as a dietitian, a nurse, or a pharmacist. For the diabetes prevention program, they also require a program coordinator, but the facilitators are lifestyle coaches, and they also require a data specialist for data collection and reporting. For staffing, as I mentioned, for DSMES, the professional instructors can be the nurse, dietitian, pharmacist, certified diabetes care and education specialist, which used to be known as a certified diabetes educator or CDE, nurse practitioner or PA. Paraprofessionals can also play a part in DSMES. So medical assistants, community health workers, exercise physiologists, and others can be part of the DSMES team, but there definitely needs to be one professional instructor involved. For diabetes prevention, the staffing requires that lifestyle coach who can be a diabetes prevention program graduate, a community health worker, a promotora, and, the CHWs and others make ideal coaches, with RDNs or dietitians and nurses and other health professionals supporting the program management and data analysis. So a little bit different staffing for these two services. Format and delivery modes. As I've mentioned, for DSMES, it can be done either individually or in a group setting. Currently, with the pandemic, we offer telehealth services, in-person services, and even DSMES by phone where needed. And so there have been additional accommodations through the 1135 waiver and other modifications to allow DSMES to be delivered via telehealth. We're finding great outcomes, and we're hoping that will continue. But at this point, it is just approved through the end of the public health emergency. For prevention, the format is typically in group, but makeup sessions can be done individually. Different modalities in the prevention program include distance learning, so synchronous phone or Zoom, virtual, which is online, which is asynchronous. So going to a virtual program is a little bit different than doing telehealth and DSMES. They can be offered in person, or there's a combination, but it's not a combination that's ad hoc. So it has to be pre-planned. So keep that in mind with prevention program. It can't be just depending on the season or different time frame. There has to be a very intentional plan. If they're going to be combination, for example, group in the first course sessions, and then follow up with virtual. Like I said, maybe in person at the beginning, virtual at the end, but there needs to be a plan. For the curriculum, DSMES requires an evidence-based curriculum that it's reviewed every year. It's got to be customized and individualized to meet the needs of the population you're serving. Depending if you're in an rural or urban area, depending on the population you're serving, they're going to have different needs. You may have to look to a different language to facilitate your program in. But many of the options that exist are very good. Two of the most common are ADCS's Diabetes Care and Education Curriculum or Life with Diabetes. The curriculum for DSMES serves as the foundation of information provided to the patients. It's a little bit different than a plug-and-play guide. It's really where the curriculum supports the backbone of content for the program, and the facilitators customize it and bring it to life. The diabetes prevention program must also have a curriculum that's approved by the CDC. They do have approved and available curriculums that are downloadable from the website. But there's a lot of free linguistically and culturally tailored options, including Prevent T2, Prevenga LT2, Duce Mothers, and a couple others. You can submit your own curriculum for CDC review, and it has to be involve 12 months, appropriate intensity, set themes, and it must be evidence-based. DSMES also allows you to submit your own curriculum if you choose. So documentation and medical records with both programs. For DSMES, it really is important to have an electronic medical record. It must be maintained. All data for the DSMES program for each participant and for the accreditation must be maintained for 6 years. Must be secure and HIPAA compliant. And you're required to submit a de-identified sample of your documentation with your application upon renewal. And if you're audited, you may be asked for a number of de-identified participant charts from that electronic medical record. For prevention, this information can be collected on Excel, an electronic medical record, or a diabetes data platform such as DAPS. ADCS offers a program called DAPS to simplify, as you saw, all those different codes and data to make reporting much easier. Reports are submitted semi-annually to the CDC. And there's additional requirements for Medicare, requiring a crosswalk report quarterly. For data collection and reporting, DSMES requires annual status reporting. The data that these programs are reporting to their accrediting organization include the number of participants they've seen over the last year, behavioral goal achievement, and then usually another outcome measure chosen by the program. And that can be based on what you have access to. Many programs choose A1C as that other outcome measure, but some programs may not have access to electronic medical records that provide that information on their participants. So they have other options that can be self-reported to track for data collection. And a CQI project is required for DSMES programs each year. For the diabetes prevention program, the CDC sets the data collection standards. So those are pretty set in stone. Reports are submitted, like I said, every semi-annually to the CDC, and analysis of the reports results in achievement of recognition levels. So certain achievement outcomes can move you to the next level of recognition. And there are additional reporting requirements for Medicare. So, are you ready to hit the road with either DSMES or diabetes prevention? So, for DSMES, to get up and running, first, you got to choose a curriculum that fits your community. But remember, the curriculum is that backbone. I think of it as the encyclopedia of information that you need to download in your brain, segments or 2-hour segments or potentially 6-hour segments, depending on what is most accommodating to your community, and it can vary widely. Even within a program, you may have sites that have different cadence depending on who they're serving. You got to find at least one eligible participant to complete their DSMES plan. So you would get a referral for that participant, and then you would do a comprehensive assessment, determine what education areas they needed, cover that, and however long it takes, once that's done, you're going to follow up with them and submit that documentation. You can develop or use an existing template to document your DSMES assessment and encounters in your EMR. Then you're ready to begin the application process. That's probably the most time-consuming piece of DSMES, is getting at least one participant through the program. They don't have to cover all content areas, but they do need to cover all areas of their interest and need as assessed in their initial assessment. For prevention, to get up and running, you want to choose a curriculum that fits your community. You want to get your lifestyle coaches trained and ready. You want to recruit a group of about 10 to 15 individuals to start about 4 to 6 weeks out before you apply to the CDC for recognition. and then you begin the program after your CDC approval date. What's next? So if you're ready to apply or thinking about DSMES, first, I encourage you to read the national standards for DSMES. The latest publication of the national standards was put out in 2017, and we have a reference for you here. You're going to read ADCS's interpretive guidance at least twice, understanding the interpretive guidance and the different requirements for those standards, seeing which ones that you already have in place. I think the biggest mistake programs make, or potential programs, is thinking they have to start over. If you're considering to do a DSMES program, what are things you're already doing in your health center or clinic that meet the standards? Those are good. And then work on the things that maybe are not meeting the standards. And a lot of the standards are administrative requirements. So keep in mind, some things are clinical, things you might need to change in what you're doing. Other standards are providing documentation for things like resumes and staffing in your clinic. Make that plan to implement the missing standards, implement it, provide that comprehensive DSMES to at least one participant, gather that required documentation for all 10 standards, and you're ready to apply. Once you receive accreditation, that is the key to getting reimbursed. You'll receive a certificate, and then you get paid for your services. What's next? A diabetes prevention program. First, read the DPRP standards. You're going to assess your organizational capacity. Consider, again, what are you already doing, and build on your current assets. Check out our trainings, technical support and technology for all things DSMES or DPP. Look at other resources that NCFH has, the CDC, American Medical Association, or NACDD, and apply as a CDC site. Applying for CDC accreditation takes 10 minutes. But remember, in order to get Medicare status to be reimbursed, it takes about a year. But remember, this journey of 1,000 miles has to begin with a single step. And so put one foot in front of the other and see where to begin. Both services can offer huge benefits to your participants. And I'm going to turn it over to Angela right now, if she has arrived.
I'm here. So thank you so much, Sacha. I think that there's so many similarities between the Diabetes Self-Management Education and Support Program and the Diabetes Prevention Program. And those similarities are really going to continue in the next section of our presentation. When we think about the shared successful strategies to enroll, engage, and retain participants so that they can get the optimal impact of both of these programs. When we're talking about the DPP, we're talking about a very intensive lifestyle change program that happens over a year or 2 years with the Medicare DPP. When we're talking about diabetes self-management, education, and support, we're talking about a lifelong series of programs that may be happening in one-on-one settings and group settings. Regardless of whether we're talking about DSMES or prevention, the more that someone is able to get that support that they need, the more that they'll be able to benefit from those programs. So on the next slide, you'll see, that's me. I'm here in 2 places, but on this slide, you'll see that there are some common strategies that we're going to talk about as we think about both DSMES and prevention. The first is building awareness among communities and among your providers. So we know already that there are many people who don't know that they have diabetes. There are many people who don't know that they have prediabetes. So it's both building awareness of these conditions, but also building awareness of these supportive programs that exist to help them prevent or delay type 2 diabetes if they have prediabetes, or to survive and thrive and manage their condition if they have diabetes. Providers also are not completely aware of these programs, so we'll talk a little bit through that. We'll also talk about developing community and clinical referral networks. We think a lot about clinical referral networks, and obviously clinical referrals are important and they're critical for a DSMT of making sure that you have that provider that's referring someone into the program. But there are also ways to kind of open up your health center to the community and make sure that you're getting those community referrals as well. We'll talk about some strategies to enroll, engage, and retain participants, to monitor health metrics and health outcomes, and to engage our whole community so that we can identify those individuals who are at risk. So let's kind of dive into this cycle and kind of see what we should do first. We might be engaging communities first. Oh, we're talking at the really big level. So as we know, diabetes is not just an issue for our health centers, it's really an issue for our whole community, our counties, our states, our countries, internationally. Here in the United States, 34.1 million American adults have diabetes. That's about 13% of the population. And about 20% don't know that they have diabetes. So even with type 2 diabetes, we have a lack of awareness. Prevalence increases with age. So as we get older, we're more likely both to develop prediabetes and diabetes. And prevalence is highest among American Indians, people of Hispanic origin, and the kind of highest group there is people of whose ancestry dates back to like Mexican origin, non-Hispanic African Americans, and some Asian American Pacific Islanders, and especially in South and Southeast Asia. So when we're thinking about our communities, there are other kind of factors that play into the development of type 2 diabetes. Diabetes prevalence is a lot higher within our rural communities than in urban areas. It's higher among people that have less than a high school education than it is among people who have more than a high school education. So when you're looking at some of these other social determinants of health factors, you want to think about low socioeconomic status, uninsurance or underinsurance, access to care, access to specialty care and emergency services, and low levels of exposure to diabetes education. 1 in 3 American adults has prediabetes. So that's 88 million people. When we look at prediabetes, even more people don't know that they have prediabetes. About 8 in 10 individuals don't know. Higher percentages of men than women have prediabetes, and prevalence of prediabetes is pretty similar across all racial and ethnic groups and education levels. So we're not seeing the same disparities in prediabetes as we see in diabetes. What we're seeing is that unequal numbers of people are tipping into type 2 diabetes from different gender, ethnic, racial, education, socioeconomic status groups. Prevalence increases with age, just as it does with diabetes. In fact, we have almost 50% of those over the age of 65 have prediabetes, but they're also more aware of their status. So about a quarter of seniors know that they have prediabetes. And if you would like to dive into some of this data, I do have the link at the bottom for the National Diabetes Statistics Report, which tells you everything you need to know about diabetes or prediabetes, whether you're writing a grant or providing your diabetes action plan at your health center. This is where you can kind of get the information that you need at the national level. So whether you're talking about DSMES or prevention, you need to identify people that are eligible to receive this care. For those with those who already have diabetes, there's a great document that kind of goes through the 4 critical times that you want to talk to individuals who have a diagnosis of diabetes. I'm not sure if Sacha covered that already, but that's definitely a resource that you want to use in terms of, after someone is diagnosed, on an annual basis, whether they have some sort of significant change in care. So you want to kind of look at the individuals that you have and make sure that you're providing them with DSMES during those 4 critical times. You also want to keep an eye on your patient population of the individuals that are coming to your health center. And get a sense of, you may be seeing a lot of people who have diabetes, but there might be only a few that are kind of identified at being at those critical times, or who you're kind of keeping an eye on because of their A1C level or comorbidities that they're experiencing. So you really want to use your patient data wisely to be able to identify groups that are most critical to include in your diabetes self-management education and support programs. You can also work with your provider's schedules when they're seeing people with diabetes, and really think about how to reach out to primary care and other specialty clinics and offices. With prevention, you usually know the people that you're seeing who have diabetes. With prevention, it's a little tricky because you may, if you went to your EHR and did like a patient registry for people with prediabetes, you might not have that many people that have that diagnosis in your system. So you can really kind of think about looking for people with an elevated BMI, because most likely you are collecting that data, or sort of adjacent comorbidities like high cholesterol, high blood pressure, and sort of putting these things together and kind of coming up with a patient profile of someone who might benefit from a diabetes prevention program. You can also do convenience screenings. You don't necessarily have to do blood-based screenings. You could do that paper screening for prediabetes. For instance, if you're administering the COVID vaccine, and people are waiting that 15 minutes after they've been vaccinated, that's a great time to do a convenience screening for prediabetes and, kind of have them fill out those 10 questions. Or if they're already participating in other chronic disease self-management group. So if they're in a group that's working on blood pressure, cardiovascular health, you can kind of tip them into your prevention group. So with all of these programs, you really are moving people kind of through this awareness process, kind of through this funnel or across the bottom of this grid, where they're kind of maybe unaware that they have diabetes or prediabetes. Then they're like, oh my goodness, I do have diabetes or prediabetes, but they don't know that there are programs there to support them. So then they're aware of the solution, like, oh, there's this thing called diabetes self-management education and support. Did you know that there's an intensive lifestyle change program? This is great knowledge to have. I know about this, but I might not know that there's this program happening in my community. Like if I see a billboard that's like, oh yeah, my dog walker, cat jogger could have prediabetes, it's very hard for me to move from that to thinking like, my clinic has this program available. And it's available at a time that I can come to the program and I want to participate. So there's a lot of steps kind of on this buyer's journey between finding out about prediabetes and diabetes and becoming most aware of this program and being able to take action. So again, here's our two little stick figures, and they're out there like, I have diabetes and I need support to help me prevent complications, or I have prediabetes and I need support to prevent type 2 diabetes. It's like, oh, wow, there's this thing out there that's called a diabetes care and education specialist. There's a program that's diabetes self-management education and support. There are people out there called lifestyle coaches who could help me. There's a program that's called the CDC Lifestyle Change Program. So these individuals have sort of moved from like, I have this condition and I'm going to take this action. Usually the first person they talk to about this is their doctor. So they go to their healthcare provider, and maybe this is something that they've like written down on a little slip of paper, as we see on the next slide. And, they're like, hey, primary care provider. Hello, primary care provider. I have diabetes and I need support to help me prevent complications. And if they're talking to a really, like a provider that's very tuned in to the needs of their patients, they will say, great, I will make a referral for you to speak to our diabetes care and education specialist. And that for DSMES is needed because you need to have that official referral into the program in order for Medicare to be billed. So whether you have prediabetes and you're just like, I want to talk to my doctor about this before I take any action, or you have diabetes and you need to talk to your doctor so you can get this referral, sometimes you end up with a doctor who doesn't know. I'm not sure I know about these programs. Am I going to lose this patient, or are they going to stop coming to see me? Maybe my nurse can just offer this, or my medical assistant can just offer this. Like, what is the DPP? I've never heard of this. Does any of this work? Am I going to be setting my patient up for a big copay or a big expense if I refer them to this program? So that's why it's important to talk to providers as well. Providers are just like us. They are overwhelmed. They have limited time. They have a lot of priorities. They have pop-up fatigue when they log into the EHR. It's like, these are all the things that you need to do. We are out there living and breathing prevention and self-management, but providers are doing a million things. They are focused on acute, it's like one patient has strep throat and the second patient is being assessed for COVID and the third patient has another issue. So they're not only thinking about diabetes prevention and diabetes self-management. They may not have ever heard about the value of these programs for people with diabetes or prediabetes. They might not see information that comes back from these programs. It's like, you sent someone here and they lost 15 pounds. You sent someone to DSMES, they reduce their A1C. They feel more capable of managing their medication. They may not be getting that information back from the provider. They worry, as I said on the last slide, if their patients can afford these programs. And then there's just logistics. How do I do this? How do I make a referral? Is it in the system? Do I send a fax? So they don't have that sense of how to do that referral program. So if you are out there thinking, I need more referrals, you want to identify providers who are seeing people at risk, recruit your champions, and think outside the primary care physician. This could be a nurse practitioner or a physician assistant. They can be your champions and can help talk to that provider who has standing to make referrals into your program. Get on the agenda. So if there is a monthly meeting, make sure that they're there, that you're there to present about your program. Keep it short. It does not have to be 90 minutes like our presentation today. It could be 9 minutes. And that may be enough to kind of bring their attention to this. Send back the success stories and the patient updates. Like, you referred this patient to me and they're doing great. Equip providers so that they can have good conversations with their patients. You don't want them to be like, here's this program. I don't know very much about it. Hopefully it'll help you. I don't know the person in charge. You want them to be able to give a quality referral into this program. It's like, this program's great. I can't tell you how many patients I've sent to Sacha, and it's been life-changing for them. She is fantastic. You want to be able to make sure that people are going to this program, whether it's DSMES or prevention, and they're excited to go and they know that it will benefit them. You want to set up systems and workflows to make sure that they are easily screening and testing and referring. You don't want to rely on people that are like overwhelmed and like stressed out to be able to do referrals. You want to build some of that into your system. And remember, you can always start, especially with prevention, with your own staff. You probably have staff that could really benefit from a prevention program. And when you meet the needs of your own staff members, your own team, they're more likely to talk about prevention to other people. There's lots of places you can look in the community to help you refer into this program. I've done education and recruitment events at all of these places, at food pantries, walking up and down the line, doing screenings, at child care centers, at senior centers. I've had some of the best meals going to congregate meal sites with different communities, and just places where people hang out. Get to know your frontline contacts. Build those relationships, identify those champions, just like you're identifying provider champions. Meet their needs first. So, they don't really know about the grant that you're working on or the program you're trying to start. But grow your partnership step by step. I was working with a church one time to do a screening, and they're like, yeah, we don't really do that, but can you do a booth at our festival? And I stood out at a festival booth handing out glow-in-the-dark necklaces and screening people like at that festival. There are lots of steps on kind of the pathway into a prevention program, and it is so much easier to tip somebody in from a monthly support group or a men's program or a women's program than it is to find someone out on the street and have them join your diabetes prevention program. You also want to work on engaging and retaining participants. So there's many, as you know, there's like many different factors for engaging and retaining your participants. You want to make it easy for them to join and stay. Increase the importance for them of joining and staying, and build their motivation, confidence, and readiness. And there are many different ways to do that. This are just like a couple of ideas on this slide. You also want to make sure your program is having an impact. So are you keeping track of attendance and retention? Those are important for both DSMES and prevention. For DSMES, you're doing your comprehensive DSMES assessment. You're looking at health status, psychosocial adjustment, their learning level, their lifestyle practices. You're making sure that they are achieving the behavioral goals that they have set for the program. And you can also choose other outcome measures that are selected by your own program. On prevention, you're focused on weight loss, minutes of physical activity, A1C reduction, and program completion. So now we're going to hear from a health center that is making it happen. And I will turn it over to Gateway Community Health Center.
Hi, thank you, Angela. Thank you, Sacha. So yes, just let me introduce myself once again. So my name is Elvia Granados. I am one of the program managers of the Health Education Department for Gateway. So let's dig in. I would like to share first some information about Gateway. So initially, the organization began as a subcomponent of the local health department, serving migrant population in 1963. However, years afterwards, in 1989, Gateway became independent. And in 1991, the organization, fortunately, received FQHC status and has continued to evolve business practices to address the growth in demand for affordable access to care. Gateway provides access to comprehensive primary health care to its patients, and these services include adult care, pediatry, pediatrics, laboratory, pharmacy, dental, behavioral health, support services such as drug assistance programs, cervical and breast and cervical cancer services, as well as family planning, and along with the health education department. So through the health education department, several programs have been implemented to prevent and control chronic diseases such as diabetes and cardiovascular disease, which comes into play diabetes prevention program. As you can see on the slide, I'll be sharing with you some numbers of the population that Gateway currently serves. So currently there's 40,238 patients, and out of those, 98% are Hispanic. Now, from those 40,000, there's 51% that are uninsured. We broke it down a little bit more, and out of those 40,000, 60% are female, 40% are male, and breaking it down a little bit more, adults are 83% and 17% are composed of children. So a continuation of Gateway's population, we currently have 7,259 patients diagnosed with diabetes. So in order to address diabetes, Gateway implemented this strategy to support these patients. So it starts from the point when the patient has a scheduled appointment. So I'll be referencing in the image that you see there. So when the patient has a scheduled appointment, then the patient attends to their medical visit, gets assessed, and then the doctor will provide verbal education along with pertinent literature, and then following with the treatment plan, labs, medication, care plan. And there is where the referral is being created to the health education department. So it's where patients get referred to our department for us to invite these patients to be part of the diabetes management classes. So there's two ways that the providers send us these referrals. Either is through tasks, or one of the nurses will provide the patient with a printed copy, and the patient will come into the department and give us the referral. And so at that point, we inform the patient about the group and individual sessions that the department offers that are conducted by promotoras de salud and community health workers. So as you can see, the sessions are conducted utilizing the curriculum, which is the Gateway Diabetes and Cardiovascular Disease Self-Management. So throughout the years, we've obtained very good outcomes utilizing this curriculum. As you can see as it follows, CHWs and health educators document in the EHR system each session that they conduct and the topics covered in each session. It's a way to monitor patients' progress based on the patient's weekly goal setting, and or goals that the patient has accomplished. At the right side, you'll see the benefits of this intervention planner integration. So benefits for the patient would be improved health outcomes, individualized care, greater adherence, improved access to care, improved quality of care, specific needs met by appropriate services. However, there's also benefits for the providers. So it would be more efficient use of their time for whenever the patient comes in for their visit, improve health control, reinforce treatment plan, extension of MD services, medical services, improved quality care, implemented clinical protocols, and health advocate additional clinic services and referral identified. At the bottom, I would like to share an example of what we've accomplished through a program utilizing this specific intervention model. So the program goal for this program was to ensure that the percentage of adult patients with diabetes with an A1C greater than 9 were at or below a 34%. So we're talking about this program that we enrolled 1,404 patients every year. So out of those 1,400, let's say, In 2017, we enrolled 937 that were diagnosed with diabetes. And as a result, 30% had an A1C greater than 9, which with this diabetes management goal, we met it because they were saying 34% or below. We were at 30. As you can see, for 2018, it stayed the same. For 2019, there was a great difference. We lowered it down to 4 points. And that, to be very honest, it took a lot of team effort with healthcare providers, with nutritionists, our registered dietitian, our promotoras de salud, our health educators. It was a teamwork that we were able to lower the percentage of patients with an A1C greater than 9. So following along, since our diabetes self-management and support model was being very successful, it was decided to utilize the same approach with the DPP program, with the implementation of the DPP. So as you can see, it's the same flow that we follow, however, with the difference that we're using the Prevent Type 2 curriculum. We are working currently for 2021, we have 2,596 active patients. At the bottom, our prevention team consists of 2 experienced lifestyle coaches, 2 experienced health educators, and 2 lifestyle change program champions, which we've included them at the bottom, which is our very own CEO, Mr. Elmo Lopez Jr., and along with Dr. Mary Cortez, she's our Chief Medical Officer. So definitely this has not been possible if it wasn't for AIDSES and that they provide us with financial means and support to implement the DPP. So moving on to this slide, at the beginning, everything was flowing very smoothly, and I think for everyone with our in-person DPP courses until COVID-19 pandemic occurred. So starting off with the challenges, quarantine restrictions. As you all know, the 6 feet social distancing, the limited number of people gatherings. Following along, limited technology access. Participants not having smartphones or depending on another family member, so they could get either they could do us like a phone call, or we could connect via video call or through Zoom. Lack of technology knowledge. So many of our participants were not familiarized with these virtual platforms. So we contacted every single patient and guided them through on how to utilize these virtual platforms. And in the last bullet, emotional distress. So as we were contacting these patients would state that they feel stressed, sad, depressed, at a certain point depressed, and how they wish that the pandemic would be over. So we would always need to address social determinants in order to continue with the implementation of the DPP. So following along with the program interventions implemented to address this issue, first of all, with reinforcement of communication with patients. So it was very important to continue that communication. We conducted weekly phone calls and or video calls just to help us maintain that constant communication. Also, the other intervention is prioritization of our patient needs and meeting patients where they are. In that said, if a patient had a laptop or had a flip phone or was not able to communicate with us, then we would adjust to what the patient resources were. On the third one, that it says opportunities for education, guidance, and support. So to be very honest, Gateway was not prepared with the virtual platforms that right now we have. And as a center as well, it was a learning experience as it was for our patients, and exploring communication alternatives to contact our patients and navigate through the available resources, which at first we initiated. I'll be explaining more in the following slides, but as we initiated our progress to eventually get to Zoom, it took us a while. And last but not least, being flexible. So the importance of being flexible with patients, because either they were not able to connect or did not have time due to job or family responsibilities. So at all times, we always took priority on our participants' needs. So now that I've explained the intervention responses to the challenges we've encountered, on this next slide, I will share with you the engagement strategies during the facilitation of Prevent Type 2. So starting off with the first one. So increase access by offering Prevent Type 2 program at different hours. So almost half of our DPP participants have an 8 to 5 job. So we accommodate to their time availability, which as a result, we are currently conducting an evening class on Tuesdays. The second bullet, which states effective recruitment strategies are key. Program promotion within healthcare providers, individualized phone communication, follow-up calls, in-person contact, etc. So we recently conducted, back in the month of February, we conducted a presentation about the DPP at the providers meeting to reach out the majority of the providers, and just emphasizing the importance of their continual support for them to refer us patients to the program. And as it says there, just the importance of continuing following up and conducting those one-to-one phone calls. It has been an essential strategy. Moving on, where it says include interactive activities during the sessions, invite a guest speaker, integrate physical activity section, demonstrations, utilize visual aids, provide participants with the time to ask questions, make suggestions, and to interact among themselves to create an atmosphere of mutual support. So we have invited one of our nutritionists to conduct presentations for our DPP classes, as well as we are currently integrating Zumba along with a variety of exercises such as kickboxing, as well as sit and be fit exercises, because some of our patients cannot do Zumba, so we will adjust them to sit and be fit exercises as well, which are performed by one of our health educators that she's a Zumba instructor. So she helped us out conducting these exercise classes. And additionally, Gateway's CEO, Mr. Elmo Lopez, has become very involved in the DPP, which as a result, he recently obtained his community health worker certification. On the other bullet that it states, establishing a relationship with participants. So we have witnessed the strong bonds that we've established with our patients throughout the DPP, which in my personal experience, it has been very gratifying. Our patients have expressed that they feel very comfortable reaching out to us if they need any assistance. And just on the last bullet, monitoring patients' progress, so that as the program requires to monitor participants' weight on a weekly basis and minutes of physical activity, we also keep track of our participants' goal setting and to keep them motivated to reach their goals. However, at the same time, it helps us identify any challenges or barriers that the patient is encountering to help them overcome those obstacles and continue with their weight loss plan. So as you can see, participants are able to connect utilizing cell phones, laptops, tablets. And like I previously said, it took us a while to get to where we are right now, which is utilizing the Zoom platform. And so first we started with the individual calls. So all the participants were contacted via phone call. We were always searching for virtual platforms in order to build and establish better communication with them, especially starting new cohorts. Moving on, it was the conference calls. So the conference calls were possible by utilizing a feature that Gateway's phone system had integrated. However, although we were able to connect with the group and talk amongst ourselves, it was not the same thing as seeing each other. However, if we were not able to see each other physically, but at least virtually. So there's where WhatsApp Web comes into play. So with WhatsApp Web, we had better communication. We were able to see each other. However, it had very limited features to have a better control of the core session, such as like muting the microphones, things like that. And there's where Gateway decided to acquire the Zoom platform, which is until now, it has been very, very beneficial. So continuing with our program goals, first of all, with the delivery of the DPP Prevent Type 2 to 6 cohorts. So right now we are conducting 6 sessions. 6 cohorts are currently in progress. We started 3 of them back in September of 2020. Our fourth cohort, we started it back in January. The 5th one, we started it in February. And the 6th cohort will be starting it next week. The second one would be certify a minimum of 2 or more lifestyle coaches, maintaining the CDC full recognition, which I will give more details on the next slide. And the last one would be to sustain Prevent Type 2 program by obtaining Medicare supplier license. So moving on to the program accomplishments. And so in August of 2020, we completed our first cohort. Based on the report CDC sent us, 80% of the participants met the 5% weight loss. So as you can see, we thankfully, we got CDC full recognition. And this month, which I stated before, we received CDC full recognition, and this recognition would not have been possible without ACE's support and technical assistance. And I just want to take a brief moment just to send a special thank you to our ACES team, Ms. Natalie, Erin, and Patrick, that are always going the extra mile to assist us in any issues that we encounter. Also, with our cohort completion, our cohorts 2 and 6, which are 6 cohorts are in progress as well, and patients' health. So not only patients noticed their weight loss progress, but also noticed a difference in their lab results. They lowered their A1C levels, cholesterol, triglycerides, and lipid levels as well. And lastly, as I mentioned previously over time, so Mr. Elmo Lopez, Gateway CEO, has become very involved in the DPP course, as he has been participating in the courses and seeing patients so engaged and motivated to make changes in their lifestyle that at that point, he decided to make a change. So as a result, he has lost 36 pounds. And he continues to motivate our patients and encouraging them to never give up. So before I finalize my presentation, I would like to say that definitely 2020 was a year of surprises. From my experience as a program manager, to obtain a group of patients for weeks is a challenge. But now doing it for a whole year and COVID-19 coming into play, it's an even greater challenge. In addition to that, being able to reach their goal and maintaining that weight for a whole year. However, it serves us an opportunity to learn several ways to deliver the DPP. And it has been a great learning opportunity for all of us and a great success. Thank you.
Great. Thank you so much, Elvia. I know that Natalie, Patrick, and Aaron and our ADCES team so appreciate the work that that you're doing. And when you shared your full recognition, it was so much excitement in our office. So we're really celebrating all of these changes with you. So thank you.
Thank you.
So just as we close out in the next couple of seconds, I do want to share some ADCES resources that can help you. We have just updated all of our ADCES 7 self-care behaviors materials. They are now in English, Spanish, French, Tagalog, and Chinese. So they are available to support these healthy behaviors, whether you have people with diabetes or prediabetes. On the next slide, we know how much the social determinants of health are important and how these socioeconomic factors, the physical environments where we live and work, affect our health behaviors and affect our health outcomes. So I'm going to talk about a couple of these behaviors as we wrap up. The first one is food security and food insecurity on the next slide. So we know that healthy eating and food insecurity has a lot of different impacts, as you see on this kind of cycle, where, people cope by reducing their dietary quality, not being able to maintain healthy eating behaviors. That has effects on physical and mental health. They spend more on healthcare. They lose income. That results in more stress and less security. So on the next slide, these are some of the assessments that you can use to look at food security. Some of you may already be using Prepare within your screening. There's also some other options available for you. On the next slide, you'll see another example of a tool, of a social needs screening tool. But I really wanted to bring your attention to this pilot, which is an example of how they're doing the national DPP within a food pantry, and to think about that as an opportunity for a satellite site for your diabetes prevention program. The other part that is a key for both people with diabetes and prediabetes is physical activity. So on the next slide, you'll see that there are some screenings for getting a sense of whether there are safe places for people to be physically active. Is there safety? Are they in a walkable community? Are there parks and trails and playgrounds? Are there active transportation options that people can use safely? Are there shared use agreements where local schools allow people to use gymnasiums when the school is closed for the day? Or is there culturally tailored programs or opportunities for people with disabilities? As Elvia was sharing, sometimes you need those programs of staying active, when you have injuries or disabilities that don't allow you to walk or run, like chair fitness programs. So these are some screenings for physical activity as a vital sign or exercise as a vital sign. And there's even more screenings under that link. The other ADCES 7 healthy care behavior is monitoring. There's lots to monitor over on the DSMES side, but we also have a lot of patient-generated health data over on the prevention side with food logging, physical activity tracking, scales that you would want to keep an eye on and make sure that this self-monitoring is happening. And then on the next slide, I'm sorry, go back one slide. On this slide, taking medication is also important. Of course, there's lots to keep in mind on the DSMES side for taking medications, timing and dose and barriers and challenges, communicating with providers. But even on the prevention side, they may be taking medications for other related conditions, and reviewing the importance of taking medications as prescribed is essential, and they may need additional support to achieve the health goals in the diabetes prevention program. So referring to their provider or a pharmacist is also important. So just as Sacha said earlier, the longest journey begins with a single step. And sometimes we don't know exactly where to go. And taking one small step will kind of help us to move forward, whatever we decide. So as we close, if there are any questions for me or Sacha or Elvia, we're happy to answer them for you.
Thank you to all for that amazing presentation. We did have a question. I don't know if we have a minute for Elvia. It was a question about how do you engage or entice the patients to participate in the classes, and if you can share any recruitment techniques that you can.
Okay, so the way that we engage, well, first of all, with the recruitment techniques, like I mentioned, in the intervention plan, mainly it's through the referrals that we received with that our patients are sent by the providers. So as soon as we get the referral, we establish that first communication by phone call. So we call the patient, we explain to them, I'm going with the example with the DPP. For example, we'll give them just a brief information of what the program consists of. Once the patient gets a feeling of what the program is, we'll invite them to the session 0. And there is where we give them the overview of what the program will consist of, which is the year long. And then the integration, basically closing all. And then along with the engage, or how do you engage or entice the patients to want to attend the classes? It is very important to establish that relationship with the patients. With that first phone call that you do, we can definitely captivate the patient by the way that we're presenting the material and what is expected from the participant as well as for the instructor. So I think that that's the key. Just connecting with the patient and definitely making sessions interactive for them. I don't know if I answered the question.
Yes. Thank you, Elvia. I think that it's great. The great job that you're doing is reflected in your data and is reflected on the heart that you put on it. And we appreciate you having that presentation today here with us. And thank you, Angela and Sacha, as well, for your amazing information that you presented. I wanted to take a last minute just to draw you to the chat box where the Survey Monkey is for the evaluation. Please complete the evaluation for this session. We greatly appreciate it. And thank you for participating today in today's session. Thank you.